Good morning, ladies and gentlemen. Thank you, Lori, for the kind introduction. I want to thank you all for being here on a Saturday. I know that you probably have better things to do, but we're very happy to welcome you here at Stanford. I'm going to try to make it as straightforward and lay language as possible, but some terms I would say in advance that they're technical. I tried to practice my lecture on my uncle, who's not a physician but has prostate cancer, and he told me that he got my message, so I don't know if that's the truth or he was just kind to me as a favorite nephew, but if you have any questions during the talk or afterwards, please don't hesitate to ask. Okay, so these are the cancer statistics. This is published every year in the Journal of Cancer in January. And although we have major advances, prostate cancer remains the #1 in the United States as far as new cases in men, and second only to lung cancer as far as new deaths in the United States. So we clearly, despite the advances that we have a room for improvement. And I hope that I will convince you at the end of my talk that we're making efforts in the space where I practice in nuclear medicine and radiology to help our colleagues in medical oncology, urology, radiation oncology to provide you with better care. So these are the types of scanners that we use in nuclear medicine. And how many of you had any of these? Okay, almost everybody. Okay, that's what I thought. So we have access now to PET MRI, PET CT, Spect CT. I'll try to show you how these work. First of all, it's the tracer principle. So what we inject as radioactivity, it's a trace amount. It's a very small amount, different from an X-ray where the X-ray comes from outside and we take a picture of what your body stops or doesn't. In nuclear medicine, we give you this intravenously most times, so we try to limit how much radiation you're exposed to. So that's why it's called a trace amount. And most of what we give you will be incorporated in a normal process. I will start with this one, which is the most commonly used agent, FDG. It's sugar. And why would we want to give you sugar? We tell as doctors, don't eat too much sugar. Why would you give you sugar for a diagnostic test? Well, sugar, it's used by cancer cells for their energy needs. And in fact, it's a little trick here. We don't give you exactly sugar as it exists in nature. We add a little molecule called fluorine 18, and that allows us to take pictures. So the principle is we give you a little bit of sugar. The cancer cells will eat more of it than the normal cells, and therefore we can see what's going on in your body. And if at the same time we do a CT or an MRI scan, we're able to pinpoint with precision where exactly those cancer cells are located or what do they do with this sugar. Now, how do these scanners look like? Let's see if the movie will work. Apologize, it doesn't seem to be working, but in a PET CT, CT is first. It is glued to a PET, so first we shoot the X-rays from outside, we take picture, then the table moves, and we detect what comes from within you. By summing up millions of those events, we're able to create a picture what happened with that compound that we injected. I'm not sure that this one will work either if the other one didn't, so maybe we'll skip through that. So at what course in prostate cancer do you come to see us in nuclear medicine? Pretty much anywhere from diagnosis to advanced stages of disease. And we go with PET MRI in early stages because MRI is so useful in providing information to the surgeons as to how the pelvis looks like, how the prostate looks like. And we add to that anatomical information things about the function, how things function in your body. At the recurrences that occur afterwards, we need to be faster. MRI takes a long time, and we want to be able to scan you faster. That's where PET CT comes into play. And then later on, if we treat you in nuclear medicine, we want to take pictures of what happened with the treatment, and that's where Spect CT comes into play. Now, prostate cancer, it's a little bit tricky. It doesn't like sugar. So very few patients will have the cancer identified with sugar injected intravenously and then taking pictures of. But rest assured, the community is working hard to find targets, and these are two of them that we have access to at Stanford. How many people heard of PSMA? A few. How many had a PSMA scan? Quite a few. So now this is FDA approved. We started using it at Stanford in 2015 as a research tool only. It is a great misnomer. It's called prostate-specific membrane antigen. It's actually not prostate-specific. It's just that prostate cancer overexpresses in about 90% of cases. So we take advantage of that to try to find cancer where it's located either at initial diagnosis or later on in the course of disease. And I'll show you some examples of that. Now, biology is very complex. If every prostate cancer would express this PSMA, then problem solved, at least for diagnosis. But it's not like that. Cancer is tricky. It finds ways to escape what we try to do with it. So that's why we have this other compound called gastrin-releasing peptide receptor. You may have heard about it as bombacin. This one, it's overexpressed in prostate cancer as well as in others, and it also allows us to take pictures of the cancer and sometimes treat it as well. Now, they say a picture is worth 1,000 words, so this is the same patient, maybe one of you here, imaged with PSMA on the left and with this other agent on the right. So let me try to explain what's going on here. As I mentioned, this is not prostate specific. So we see salivary glands, these produce saliva. They also have the same enzyme, just like prostate cancer. That's why we see them. And then we have a little bit of liver clearance, a little bit of spleen. Like everything that you give to someone, there's two ways of getting out of the body, either through the kidneys in the urine or through the liver in the bowel. Most of what we give with this class of agents is cleared by the kidneys. That's why we see kidneys, the right and the left, as well as the bladder. So this is normal. All you see here is normal. When you have a scan with PSMA, we try to see if there's anything outside of this normal distribution. If it is, then we try to decide if it's related to cancer or not. So that's what happens when you come to us for such scans. Now, as I mentioned, up to 90% of prostate cancers, we have this probe. But what about the remaining, anywhere from 10 to 50%? Well, for those other ones, you have access to this other compound, which is research. But you can see that there's a difference, right? Do you agree with me that there's a difference between how these images look on the left and on the right? Well, the most important thing is that we don't see salivary gland, right? So if we decide to treat with this class of compounds, this may be beneficial in reducing the side effects from salivary gland uptake. But we see other things. We see the pancreas. And you may wonder, are we doing damage to the pancreas? The answer is no. The pancreas is actually very radioresistant, so we don't do harm to the pancreas when we give these compounds. Another advantage with this research one is that it doesn't bind to the kidneys, so there's less of a chance of doing any damage to the kidneys. And it has very little clearance through the liver, so therefore it's very clean in the abdomen and pelvis where we are looking for prostate cancer lesions. So how do we use these two compounds at Stanford? These are some of the research projects that we do together with our colleagues in urology, medical oncology, and radiation oncology. How many people had a negative biopsy first? Quite a few. We heard from the speaker ahead of me. So what happens is if you biopsy blindly or if you biopsy based on an MRI, you may find most of the cancers, but not all of them. So what we try to do in this study here with my colleague Dr. San in urology is take men who had negative biopsies before or negative or equivocal MRI, but the PSA was still going higher and higher, or the PSA density was increased. So we gave these two agents, the PSMA and the bombacin, and then we did a PET MR and we tried to see if we find more cancers. And guess what? We did find more cancers. And this is the beauty of being able to do cutting-edge research, to having access to novel agents to be injected. So this is an example. We're looking at a slice through your body in the pelvis, and we're looking from the feet up. So this is left, and this is right. This is the image from the PET using PSMA. This is the image from the PET using bombacin. This is the PET and MRI overimposed on each other. This is the MRI. This is a picture of the whole body. And you can see that there's something in the prostate that should not be there. And that was biopsied, and that turned out to be the cancer. Now guess what? If you see these dots in green, those were the prior needle tracks from biopsy that was not guided by PET. And although it's tried to be done as saturation biopsy to sample as many parts of the prostate as possible, sometimes the cancer can be missed. And that's exactly what happened here. And that's where the beauty of these new agents were, in that they allowed the surgeon to target specifically the area with cancer. And this is the one in red here in this 3D rendering of the prostate. You're going to hear right after me from Dr. Son about focal therapy, high-intensity focused ultrasound. This is a method that works in selected patients with prostate cancer with localized disease. You pretty much rely on knowing exactly where the cancer is located and you hit it with a high form of energy. I'm going to stop there to not steal the thunder here for Dr. Son, but it's important to know the true extent of disease. And then the question is, how do you know that it works? So here we have an MRI. The needle tracks in green show where there's normal tissue, and then in red it shows where cancer was found. On the top row are the images from PET and MRI showing an area with abnormal localization of this agent on the right side of the gland with both agents. And then at the bottom, 6 months later, the signal is gone. So that tells us that perhaps the treatment worked, and perhaps there's no need to repeat the biopsy. And I will say that these are preliminary results. These are a small number of patients that have been studied so far, but the preliminary results are very encouraging that perhaps in the future, if this data will be sustained, perhaps a repeat biopsy will be needed only in a smaller number of patients than it is needed now. This is with radiation therapy. So this dot here should not be there. That was biopsy proven to be the cancer. And 6 months later after radiation, you don't see that dot anymore. So that tells us that the cancer is gone. And this is only because you have the biology from PET being able to tell you that the tumor has lost the ability to be viable. It lost those receptors that we are interrogating when we inject these radiopharmaceuticals. And this is another such example with the lesion seen in the gland. This patient will be treated, will come back to us, and then hopefully we'll find out that the cancer is gone, and that will preclude the need for additional biopsy. What about prior to surgery? MRI is very useful, but in selected patients with high risk, there is a need for additional information, and PET is able to provide that additional information. PET is able to tell us if there is disease located outside the prostate. When you look at an anatomy on CT or PET, you rely on size. But by the time you get to a size that's greater than a centimeter, you can have billions of cells there. So if you rely simply on size, you're not going to be able to always find early the disease. If you rely on these biological processes where we're able to interrogate what's going on in these lesions, even when they're smaller, then we're able to identify disease earlier. And here, on the top is a PSMA, on the bottom is the other target, bombacine. The prostate cancer is seen very clearly with both of them. However, there's a small lymph node that I would argue it's easier seen with one of these two. And it's the argument why going forward, although we have access to PSMA and it works greatly in majority of patients, for selected patients, it's good to have access to other ways to interrogate the biology of cancer. Now, we're also able to derive certain things from what we measure when we take these images. So this is work from one of my colleagues, Farshad Moradi. He's actually able to tell how long it will be until a recurrence occurs, depending on how intense the signal is on imaging and whether there are lymph nodes at initial diagnosis or not. So this is very useful information, and as we continue to scan patients, our data will become better and better, and we'll be able to have nomograms where certain input functions are placed, and then that will be able to tell us when we should start worrying about measuring PSA, et cetera, et cetera. And similar predictive value can be found from the other agent, from bombacine as well. Now, our largest experience with this research agent is at the biochemical recurrence, so after the initial treatment, where the PSA starts creeping up again, and then the question is, where is it coming from? And for many, many years, we were not able to tell with certainty unless the PSA was high enough to find lesions that were large enough for the CT or MRI to find. But now with these new biological targets, we're able to find these recurrences earlier. And this is an example of how long it takes to get something from an idea to actual close to FDA approval. We started this phase 1 study in 2013. We still don't have the approval, but we have almost the entire data to submit to the FDA for consideration for approval. So it takes a long time. We have to do it safely. We want to have to prove to the regulatory authorities that what we do is safe for you and providing the information that's needed to the treating physicians. We've published this data already demonstrating that these new agents find disease. We also published the data showing that they're predictive of how aggressive a cancer will be. And we also published data showing that it makes sense to use both PSMA and this other agent in selected patients because although many lesions are seen on both scans, there are some that are only seen on one. And if you don't do both, then how do you know that you're not missing some lesions. So it's always good to have access to more information because that will provide us with the keys to unlocking the mystery of the disease. Now, how many of you heard of Terranostics? Terranostics? Nope. Okay, well, let me try to tell you a little bit about that. So let's think about this as the concept of a door lock and a key. Okay, if you have a lock, only a certain key will unlock that door. So if we think about that for what we inject when we do these images, the key can be PSMA, for example, right? And that will unlock the door to certain prostate cancers to deliver either an agent that allows us to take pictures, diagnostics, and if we see the disease, then we have something else attached to it with more powerful radiation. That's the therapy. So diagnostic and therapy, therapy and diagnostic, theranostic. So if you see the disease, you treat the disease. That's a major principle here. And it has been used primarily for PSMA. There is now a compound, Luteum PSA, that is FDA approved, and some of you may have gotten it already. And this has been shown in a large phase 3 study, the VISION study, of which Stanford was a part, and Dr. Srinivas was the local PI. It showed to reduce the risk of death and to reduce the risk of progression in patients who were heavily pretreated prior to the treatment. So this is the data that led to the FDA approval of this drug, and we've been using it at Stanford for quite a while now. Now, it cannot be given to everybody. This is data from the Peter Mac group in Melbourne, in Australia, showing patients who are unlikely to benefit in red to patients who are likely to benefit in green. So again, it shows that if we see the disease, then we can treat. But if we don't see it, or if other targets, like if the tumor consumes more sugar than expresses PSMA, then probably the treatment is not going to work as well or is not going to work at all. So we are using these eligibility criteria here at Stanford as well. And I think that as we see more and more patients, we will learn more and more as to what is the optimal combination of these approaches for treatment. You know, there are people who argue that let's just give the drug blindly. Sandy and I wrote against this because we need to see what you treat. Only then you can treat what you see. So we are advocating for a systematic approach to these treatments and to be very well informed before deciding whether to go ahead with them or not. These are some examples from what was published. A lot of disease at baseline in this patient here. After 2 cycles, a decrease of signal, and then after 4 cycles, only the normal distribution of the drug is seen. So many of the patients achieve such a response. Now, what's happening in the future? We have another form of even more powerful radiation. It's called alpha radiation. It's a little bit more difficult to handle because it's difficult to detect, and it punches a lot of damage to the cells. It's under research now. One of them, actinium-225 is the name. But the preliminary data show that you can take someone with extensive disease, very high PSA, almost 3,000, and after 3 infusions of this drug, the PSA decreases significantly. And then after more infusions, it's almost undetectable or undetectable. This is undergoing research. It's a few years away from consideration for approval, but it's something else that will be in our armamentarium for selected patients. I want to end with a little bit about where we are in nuclear medicine. Here in the main campus, right above the cafeteria, the 300 Pasteur Drive building. So the patients enter here. There's a waiting area here. On this side, we have the Spect CT machines. On this side, we have the PET CT machines. 5-6 years ago, we realized that these approvals will come for these therapies. So we started working with the hospital administration to renovate a space that was a physics lab. This was the design from the architect. We worked with patients who provided input about what should be in a room and what can make the stay there with us more convenient. And after several months of construction, where the walls were gutted down and everything was renovated, this is how the space looks like now. So these are rooms that are comfortable. This is space where we have a nurse practitioner, a nurse, a physician office as well, a medical administrator. and we're well positioned to welcome each and every one of you who will need this treatment and when they will need this treatment. I want to also take a moment to introduce the staff of our Diagnostics Clinic. My colleague, Dr. Karina Maria Paricci, leads the program. Kat is our nurse practitioner. Valentina helps with any questions related to physics. Corinne relates to anything that we give you. Tina is our nuclear medicine manager. She's a technologist, and Elena is our clinic MA, clinic coordinator. They don't work by themselves. We all are helping them. I want to say that in the year since we opened, there were about 445 patient visits, 357 treatments, and we're the first center in the US to achieve this designation as a comprehensive radiopharmaceutical therapy center of excellence. We're also able to do very fast Spect afterwards. Typically, if you get a Spect, use a standard machine, it can take up to an hour, but with our investments in technologies, this can be done in under 10 to 12 minutes. We also give back to the community. There's a blind spot between a phase 3 study ending and FDA approval, which can take anywhere from 6 months to more than a year. So what do patients do if they need a scan then? Well, they can go to a place where they pay for it out of pocket. What we're able to do here was to offer these scans at no cost to patients. So if you got your PSMA 11 or PYL here at Stanford between 2015 until last year when they were approved, there were no cost to you. And that's because the hospital agreed to not charge any technical fees for the use of the machines. And we didn't charge anything for interpreting the scans or for making the drug that you receive. So we love collaborating with our colleagues in the other specialties as well as to giving back to the patient community. And speaking of collaboration, I want to acknowledge my colleagues in medical oncology, radiation oncology, and urology. When you come to Stanford, you come to a team of multidisciplinary physicians who work together well and who look at what is best as far as your care. And this is our team in nuclear medicine. It is now more than 60 people who are dedicated to excellent patient care. Sometimes there is a delay when you come to see us. It's not because we don't care. It's because there are other things that can pop out urgently. But please know that you're always welcome when you need us. So I hope to not see you anytime soon. But if you'll need to see us, we'll be here to take good care of you. And with that, thank you very much for having me here today.
Thank you so much, Dr. Iagaru. Very informative. Always continue to learn from you. And we're going to take the next few minutes to do some questions and answers. We have some questions coming in both online and in person. Question number 1 is, how long after completing the treatment does a patient need to repeat imaging to assess treatment response?
That is a very good question. I don't think that there is a precise answer right now. Our workflow is such that we get a scan prior to treatment for eligibility, and then we do one right afterwards to document the response. We're also scanning after each infusion, and some preliminary data is telling us that we can tell for many of the patients, even after the first or second infusion, how good the response is going to be or not. But that's still research. So the current standard of care workflow is to repeat a scan after the 6th infusion. And the scans are not the only ways to evaluate response. A simple blood test like PSA sometimes give you even more information if it drops to undetectable levels. So imaging is not the only way, and it's not in a vacuum by itself. It's in the complex medical care that you are receiving, including with colleagues from medical oncology, urology, and radiation oncology.
Thank you. Next question. When will the MR-Idiom machine be working? This is something I'm not familiar with. MR-Idiom. And let me see. This is a type of Linux, a new type of Linux that allows real-time stenographic targeting treatment.
I think I know what that is about, but I'm not a radiation oncologist. I know that Stanford installed one. Hopefully it's up and running, but I don't have the answer. There's also a PET-guided radiation machine now. So it uses a signal from the PET to allow the targeting with external radiation. That is undergoing FDA evaluation, and the first one worldwide was installed in radiation oncology here at Stanford as well.
Regarding the PSMA PET, why is it not the standard part of the workup since it's so accurate?
Actually, The NCCN guidelines do include PET right now for majority of patients, but we also need to use it in a way that's compatible with what we know about when it's useful. So I don't think that anyone should just get a PSMA for whatever reason. It should be done in an appropriate clinical scenario, and there are appropriate use criteria available from the professional societies.
Kind of expanding on that, does it have a role in continued active surveillance following focal therapy?
I don't think that there's data to make that statement. I think that people are looking into that. Again, they're simpler tools for surveillance, just like a PSA measurement, PSA doubling time, PSA velocity. There are other things that can be used. If and when PSMA PET can be used for surveillance, it's a topic of research, not well established now.
What would you do if the cancer does not show on the MRI?
I'll do a PET. Obviously, I'm biased. No, I would discuss with your doctor, with your treating physician, and she or he will know what the next best step will be.
Great. Any other questions from the, yes?
Yes, Luteum, what is it, 617 or 177? 617?
Lutetium-177, it's the isotope, so so the radiation emitter is Lutetium-177. PSMA-617, it's the key. It's the key that's unlocking the door.
Okay, yeah. But my question is, when did this lutetium, what is it, 177 or 617?
177.
Okay, right, okay. At least I'm paying attention.
Yes, you are.
What's the date?
I don't have the precise date. It's last year.
June or what?
21.
Because the doctor told me they expected maybe by the end of 22.
There's a lag between FDA approval and commercial availability. Yeah. The company that makes the drug needs to be inspected by the FDA to show that the pharmacy where it's made makes it to the specifications that received the approval. So unfortunately, that process is not in our hands, in your doctor's hands. That has to do with when the FDA inspects it. Yeah. On top of that, and some of you may know, there were some delays this year because the manufacturing had some issues that needed to be addressed. So for a few months, this was not available. But it's slowly trickling in clinical practice, and we started using it a few months ago. And there is still a wait list because of the manufacturing issues, but it is FDA approved and commercially available now.
Okay, well, again, what is the date the FDA approved?
I don't have that off the top of my...
Not totally in use, but when did the FDA approve?
2021.
21, what's the month?
I will give that back to you. I don't remember.
So my second question is the slide you had up here. You said the spread decrease was like 60%?
Some of the benefits for progression free, yes, it's about 60%.
Death was down by 38%?
That's correct.
Okay, that's all. Thank you very much.
Oh, you're very welcome. Sorry about the date confusion. I needed a second coffee this morning.
Okay, I think we got two more questions, and then we are...
Another question. When do you expect after the labs, the med manufacturers that make Lutetium-177, when do you think that'll be complete and the FDA approved to be universally available?
Oh, it is available now here at Stanford. Each institution has their own contracts, and I am not privy to all of that.
2 months ago, Stanford started using it.
Correct.
Thank you very much.
You're very welcome.
Two more questions. Number one, are there any trials where the PSMA 617 are being administered for intermediate prostate cancer?
Let me rephrase that a little bit. There are 2 studies where lutetium PSMA is administered at earlier stages of disease, and Stanford is a part of both of those studies, and I encourage you to talk to Dr. Srinivas and the other colleagues in medical oncology about eligibility for those studies.
Thank you. And the last question, what are the long-term effects to these isotopes for detection and treatments?
Can you repeat that, please? Long-term effects for detection and treatment?
Of the isotopes for detection and treatment.
Well, I don't think that they have a side effect as far as detection and treatment, but they're drugs. So like every drug, they will have some adverse events. In fact, one of my senior colleagues when I was an intern told me that if water was medicine, you will be at risk of drowning if you drink too much. So, I mean, these are not harmless. They're drugs. That's why it's important to take them when referred by a physician who is experienced in treating patients with prostate cancer.
All right, thank you so much. I think we gave you a good amount of questions, and Dr. Iagaru is available if anybody has any questions afterwards. He's happy to take emails. So thank you so much for your time and the information.
Thank you. I'm available via email because we have a retreat that I have to attend afterwards, so apologies, but send me your emails if you have them, okay? Thank you.